everybody. Everyone enjoy the lunch? Yes. Suitably filled and comforted. It was very nice, wasn't it? So, great. I'm really pleased to have this session with you. I can't say enough what a pleasure it is to actually talk to you on this matter. I am like a stick of rock like this, I'm afraid, so it does run through me, workforce. I'm a big believer in all of that stuff. There is going to be some things which I'll touch upon which probably might be a bit challenging, a bit difficult. I acknowledge that. I have the same issues, to be fair. There's some questions in there that I think, right, okay, question my thinking. So if at any point there's something you want to discuss, there's not time during today, do get in touch with me and we can have a bit of a session on what's going on with that. So, I'm the AHP Workforce Improvement Lead. Just to recap, so AHP workforce, third largest workforce. In terms of why that's so important, obviously our workforce is our means of actually delivering the care that patients receive. It's also our biggest cost, and for that reason it's so important. Where we're at, so for me it's about 3 pillars almost. So we're looking at the evidence, and we've talked a lot about that this morning, but using all of that information, so whether that be the activity that our workforce delivers, whether that be the workforce levels, thinking about some of the opportunities of safe staffing, so we know what nursing have done with that and how they've been able to use that information well. But also thinking about, and I'm going to go back to this again and again, I'm sorry, but ESR, the accuracy of it, it's absolutely fundamental to everything we do. And I would say if you can have an action that you go back, that's the one thing I'd like you to take away from today. All of that really helps to plan, so we're talking about giving you the skills, the information, all of that evidence to be able to put across what you need from a workforce. Utilising that evidence really to inform your plans, it's absolutely essential. Looking at benchmarking, so some of the tools that I'll talk about later, we are working through about how that can be developed to help you have evidence again to reinforce the plans, but also thinking about the supply. Have you got the supply of the workforce out there that you need to do what you need to do? The other options, we're talking new roles, so I'll go into all that detail a little later. But also thinking about the integration. So in terms of the AHP workforce, obviously we've got lots of professions that form that, but our strength is being integrated in the whole workforce plan, thinking about what our offer is. It's all about really, and I've put lots of C's down here, and that's where I see you being with this. It's really getting you to that place. So aims and objectives, quite alright. So it might be something very important. So in terms of objectives of the session, so it's thinking about the resources that are available, how we utilise these currently. You've each got a pack. Hopefully all of you got a pack. If you haven't, I will commit to you that you'll have a pack very shortly. I'll send that over to you. And that pack details your trust workforce plan. So that was the plan that was submitted in 17-18, and that details what your trust has actually signed off as reflective of the AHP workforce. We'll talk through how to interpret that plan, and I'll go back to my planning review days and share some of the thoughts I have on that, but also thinking about the planning process. I'll give you an overview about how it actually works, so what happens. There's also 6 steps methodology. It is the well-renowned planning methodology for workforce. It doesn't just look at workforce, it's multifaceted in many ways, so I'll run through that. But also, what are we doing to actually develop these things and help it progress and get you to a place where you've got this information much more available. So I was kind of asked when I was looking at this to pinpoint where I think my work really sits, and I think at that day, and probably the position that the moon sat in the sky, I felt it was over here, but on reflection it really is everything in terms of workforce planning. It touches everything, it's so important. And I think just bear that in mind when you're thinking about some of the evidence that we've gone through this morning, how you might use that, just thinking through about the tools that are readily available to you. So, neatly, what tools are available? It is worthwhile recapping why workforce plan. If we look at, and I am going to make some comparisons to the nursing workforce because they are a little bit further on in terms of their workforce planning, their evidence, but we really need to be in a place where we understand the workforce levels required. It gives us that space to know when we're above, when we're below, when is the risk, when do we need to put in mitigating actions. As I say, it is our biggest cost, and Ros rightly said we do need to be accountable for that and explain what we're doing. But it also sets staffing levels, so you move to a place where you're moving from feel to fact. And I think that's quite an important thing to say, is that we just don't go on what we think we need, it's what we know we need. And it's really being in a place where you can actually, if you know that there's something off, if you've got a number of people off sick one day, you didn't plan for that, but actually you know the plan was this, so you know you're going to be short, how are you going to deal with that on a day-to-day basis? So it is the operational elements as well, about day-to-day planning. So what's available? Lots and lots, which is fab. I'm not going to do Ros's areas because I just will not do that any justice at all. But there is obviously a lot of information there that is in development, that's currently available that you can use. But I'm going to talk through some of the things that we've actually mentioned of good characteristics of workforce planning. Early in the year we released an operational workforce planning toolkit. So everyone's got access to that. It's aimed at HRDs, it's aimed at anyone who touches upon workforce planning to do a bit of a health check about what their workforce plans look like, what's the process supporting it, how does it all work. And this is just pulling through some of those themes. So, workforce plan health check. Look back at your plan. Where have you been? What have the problems been? What's been successes? Does it feel right? Is the unmet need? So just thinking about some of those questions there when you look at your workforce numbers, and you may well want to use your planning packs that you've got today to reflect on that, whether it feels right. Activity trend. So how has activity been? You've been able to meet it? Not able to meet it? Some of those questions. Have you had the right people in the right place at the right time? Just thinking through some of those questions. Cost improvement. So cost improvement, what happens? So you may well submit a plan and then a cost improvement gets applied after. Is that how it's working for you guys? Do you know what the SIP is straight away before you start your planning process? So just thinking through, how is that actually working? Flexible workforce. So this is where it gets into the nitty-gritty. So is your substantive workforce enough? Have you had to use flexible workforce? Has that been okay? Is that what you'd planned to do? Has there been times where you've had to use flexible workforce, such as bank and agency, where you've not planned for that? So just thinking through, is that because of the activity? Did you have a peak that you just could not meet? So just thinking through that. Patient experience. Now I'm a big fan of this one because I don't think it's used enough. So let's start with the negative. What complaints have you had? Has there been any complaints relating to staffing levels? Anything there that you could take away, that you could apply and think, actually, this needs to be incorporated in the workforce plan. It was a risk, I've identified it, this is what we need to do. But also, what's been working well? What's been the good feedback? And just thinking through about what that means. Professional judgment, of course you're the experts, but don't get hung up on what might have not worked a year ago, 6 years ago, whatever. Doesn't mean it, because it didn't work then, it might not work today. So try to challenge your thinking on that. And what I would say is, when you are looking at your plans, do have an eye out in terms of what's going off with your clinical strategy, what's going off with your broader workforce strategy, and think about those things. So example being, And back in my trust when I was workforce planning, this would be quite an often scenario. There'd be plans to expand perhaps some of the services, and then AHPs is an afterthought. So how do you get underneath that? How do you get in there and really be at the centre of that table? Don't think I'm being forceful enough with the clicker, I'm sorry. So, plan. What do the plans say? I'm going to whiz through it. I'm going to cover all regions, and it's very graphy. So I apologise in advance. I am a data geek. Right, so nationally, AHPs plan to increase. What I would say is when you look at the 18-19 actual, which is the column there, and bear this in mind because I've got 4 more slides to go through which are just like this for your pleasure. 18-19 plan, we're above it. That tells me that the plan isn't representing the AHP workforce. How does that feel for people? Does that, and what does that mean when you look at your plan? So I am going to whiz through, but just note some of the increases and decreases. I'm sorry because you can't quite see. But in terms of looking at the qualified paramedics there, qualified paramedics was the biggest increase above all staff groups. It's no surprise, I don't think, with anyone. But I would just question whether some of the increases and the decreases, whether those feel right. Same applies to your plan. London, it's decreasing. Got a mix in the room today, I know of South Trust as well, so just to bear that in mind, but the same pattern. The plan's below the actual.
So, just ask, when you say the plan, is this
Yes.
from the data that trusts have given, has been put together?
Thank you, it's a very valid question, and I just assume that everyone knows the same as me, so I'm sorry for that. So in terms of the operational planning process, every trust provider will submit a plan each year. It could be for a year, it could be 2 years, 3 years. It depends on the nature of the request at that point, but it happens every year. They submit the plan along with, it's the workforce plan along with finance, activity, and a triangulation file that brings it all together. That is submitted from your trust. So what you've got in front of you is your data, and it's signed off by an exec, and it will be worked on by a workforce planning lead. I would add, if you need to know who your workforce planning lead is, who signed that off, I can help with that. So if you need a bit of matchmaking, I can help that along. Certainly. Does that help answer that? Is that okay? So Midlands and East, it's decreasing again, same pattern, staffing post actuals above plan. So why is that happening? Is it that plans are being submitted? Is the SIP being applied after? How does it feel in your trust? What do you know is happening? Do you don't know what's happening? Is that a question in itself? So, again. North. So it's planning to increase. Same pattern again. And I am whizzing through these because I'm just trying to prove a point really, that the plan should really be above the staffing post level. I think that's something to bear in mind. The South. Question, sorry.
So while you're looking at these, I think it might be useful for you kind of to think not just organisationally, nationally, in terms of the challenges that we get back. So in terms of cost improvement and productivity, you know, the challenge we get is, well you're over-established. Your trust is saying this is the plan for the workforce, but actually you've got this many, so nationally we're over-established for AHPs.
And it really does make it challenging to say with conviction what the workforce plan is for AHP. So when we are asked that question, the data as it stands, we can't really hang off the back of this that well. And there's lots of opportunity off the back of that I think we are genuinely missing out on, aren't we? That we've just not got that evidence base.
Is there any what's the right word? Is there any link between the work we've done about leadership and the workforce planning? Because, you know, who submits the data for what our staff need?
I absolutely suspect there is, Chris, and I guess that's one of the reasons to flag all this with you guys and for me to ask the question to you again about the job planning. You know, how many people in this room are responsible for implementing job planning wholeheartedly for the AHPs in your trust? Again, I'll probably ask the question back to you is, are you responsible in your organisation for challenging the workforce plan and being part of that workforce planning process? And if there isn't that person in your trust doing that, then it shows a leadership gap there, I would say, is my view of it.
So the information that you've got here, does this feed into education? Because the problem we've got is they're not training enough of us, and you can see we're running out.
It does. There's probably two separate issues to take from that, in that the same plan is submitted to HEE, so we are more aligned. Obviously, that helps with what we're working on in terms of the announcements this week. But it's also worthwhile considering about what the bursary means for that as well.
Because I know
that's another day.
I can't get OTs, but the numbers are decreasing because of the bursary going.
So historically, yes, this would have informed how many places HEE commissioned, because there was the bursary, and that was one of HEE's responsibility to commission those placements, so that we knew that we had the right workforce, or we were planning for the right workforce. Now HEE doesn't commission anymore.
No, but HEE still pays for placements, don't they?
There's some professions, very small professions, where they are involved in that. Generally speaking, most trusts will be engaging with the HEI and thinking about what that course will be, what that will mean. So that might be another self-reflection there about what is actually happening to help with those OT numbers as well.
Because everybody seems to be opening physio courses left, right and centre, but actually that's not based on anything. It's a money grabbing thing.
Well, they're businesses, aren't they?
We just opened one OT course.
Bit of promotion there. Squeezed it in.
Any of you got any teenagers in the room who want to become an OT?
Contact.
It's just we've been asked to provide loads and loads and loads of physio placements, but nobody's actually come to us and said, is it physios that you need? Because it's not physios.
It's a massive challenge. It's a huge challenge.
Actually, though, as a good business, if you, as Joe said, if running as a business, you should do some. We have to spend quite a lot of time doing feasibility, so to say what's required out here. Because most we knew our OT students would come to us would be want jobs locally. So we needed to see there was, and that they would provide placements. And there was people saying yes, please, we need them. And so,
but nobody wants to take on apprenticeships in here.
No, recruitment is hard though as well, because we jumped to 40 and we couldn't fulfil all those 40 places. We didn't have enough people with the right credentials to come to fill 40 places.
So I think the bursary is it's a whole can of worms there that I think we could spend a whole day on. So we'll not go into too much detail on that one.
But you can see though where there are courses that are more, I guess, sexy or that will become oversupplied for those professions.
That's my fear, is in a few years' time we'll have a lot of physios again, as we did a few years ago.
We'll have loads of them hanging around.
But we're nice people, Jen.
Don't doubt that at all.
Sorry, guys. No, I'm just being light-hearted.
According to
I'm just
Rob.
being light-hearted. I wanted to make
in the wrong place.
I wanted to make another point, if I may, Helen, about the whole, when you're looking at plans and actuals, and Joe's right, like nationally, this is what we report delivery of our programmes against, so we might report the pay spend against the planned pay spend, and obviously we always look as if we're overspent because the trust plans aren't that accurate. And one of the things that we also see is where the plan is less than the actual, there might be a significant SIP that has been put against it, that the trust has told NHS Improvement that that's the SIP against the AHP workforce, but actually when I speak to the trust on engagement visits, they're not aware, the AHP service might not be aware that they've got that significant SIP. So it's kind of really quite flawed in a lot of ways, and we're trying to make it a much more meaningful planning cycle.
And for more reasons than little, I'll come on to that shortly, the sorts of things that we'd look at when we're reviewing a workforce plan, because it might be that finance have had their hands on it trying to apply the financial envelope, so I can give you our point of view, what we'd look at from a workforce perspective, so you can then place that challenge back based on your pack. So that's what I'd really encourage you to do, is to find out who your workforce lead is. Is ESR right in the first place? Because obviously that will be informing your plan. But also work with them to understand how that plan's been derived. But we'll come on to that shortly. So in terms of probably how a plan chart should look like, this is it. So your plan is above your actual. That's typically what you'd expect from a plan. The gap will be potentially vacancies as it stands. So it's just thinking through again what that means when you look at your plans. So is your plan below your actual? Yeah, so I'm seeing some nods.
I don't mean to, so my brain is thinking about this, so potentially if you were really good at planning, your plan might be the same as your actual. It wouldn't necessarily have to be more than
It
your
would,
actual.
and what you would see actually, rather than it being a flat line, you might see, if you take John Lewis, so John Lewis are going to get into a really busy Christmas period, so if you look at their plan would be going up here, because they know they need more people, they need more elves. I could even go so far, but I'm not going to go there, let's not think about that in that terms. But you would see the peaks going up, and there's not that. And does that happen in your services? Have you got peaks in the year of services? So
around graduation, peaks.
Yeah. So you may need more people on hand to kind of see that through.
Does the way when they send and present this information, do they see it? They won't see it in this format, presumably, will they? So they're sending figures, are they? So are they interpreting what we're seeing here?
And what I perhaps should have done is held up what typically a plan looks like, but it's not indifferent to what Ros held up on the slide for the activity. So it's an Excel file generally. There is the opportunity to record some narrative as to say why, what, therefore, all of that stuff. But it's generally 3 Excel documents that come in to reflect the finance, activity and workforce plans.
I guess the other thing about this slide as well that I find really fascinating is the incongruence between registered and support qualified, registered and support staff.
And we saw this with nursing. So when we were doing safer staffing, we saw that unregistered nursing would perhaps be higher in terms of numbers because the availability of that workforce there. So that gets you back into the space of when you're doing your plan, do you know the supplies there in the first place? Is that the right answer? Do you need to look at other solutions to deliver the service? So it's a good point, Jo.
Is there also something around that in that if you like when we've got the qualified staff, sometimes we employ people before they qualify for uni, so we employ them as support staff to start with in the vacant qualified posts. Does it show something about we're employing more support staff into the vacancy that we can't fill?
I think it gets back to, if we unpick that, so at some point you've made an assessment that that person is safe to do those duties. So you've done that on that occasion. So I guess, is there other occasions? Just generally thinking that through, is there opportunity there of that of a more regular kind? Would that be right? And it's just thinking through the pathways again. Sorry, Jo.
So I think that's getting into the weeds there, which isn't a criticism, but those are maybe some of the narrative that you're seeking to find as to why this looks like it does, and if it's right, wrong, or indifferent. That might be some of the narrative that you would want to see. Well, why does it look like that? And why when we planned for that, actually we got all these others? That might be one of the reasons. Might not be.
So you've got your plan in front of you. I'm going to give you a quick whiz through about what I would look for when I was reviewing workforce plans, and I've done a fair few. So, big caution, this is your data. It's not ours, it's yours. I've just shared it back at you. It's what your trust has been submitting. So that's something to bear in mind there. It's signed off by an exec. So somewhere, at some point, there's been a conversation around a board table that this looks okay, this is what we need. The groupings are based on occupational codes. The occupational codes are used in ESR, and that's how you basically group your staff.
The problem
So
with
if-
that is, if you've got a member of staff, like we employ therapy support, they're not OTs, they're not physios, but we have to put them under a code. Generally, they're put under the OT code because it comes first on the list. So therefore, it looks like we've got a lot of occupational therapy staff when actually we've got a lot of therapy staff.
So isn't that a massive opportunity, because there'll be the opportunity to record it right.
But we
If I
can't
play-
change the ESR code.
No, but if I play it back to you, that in terms of HR, they're making assessment themselves, who are not clinical, about
Yeah.
how those jobs should be coded up. If there isn't the code there, they have the opportunities to feed into groups about what new codes are
Because
needed.
they just tell us there's nothing we can do about it, and that's just the way that it is.
There's definitely something that can be done about it. So
You say that they're
Yeah.
just the codes, they're out there, they can't be changed. So you're saying that they can challenge
And
that.
do you think that when you look at the occupational codes, they are not reflective?
No,
as it
because I need
stands?
a combined therapy code, definitely a combined one.
Okay, I think we'll take this one offline, because there is ways in which
Right.
things can be done on ESR, such
Okay.
as multiple assignments, to get
Okay.
around perhaps some of
Okay.
that.
That'd be helpful.
So let's have a
Yeah.
conversation in a bit during break.
I'd like that conversation.
Yeah, let's have a bit of a group on that, yeah? All for that. Fabulous. So, WTE is the currency. So, we're not talking headcount here, we're talking about contracted WTE. What that means is bank hours will not be included. That's not included in this mix. An agency won't be included because they are not recorded on ESR. So, just making that quite clean about how it will work. In terms of the actuals, it is ESR, I'm afraid. So it's code independent. Have a look at your codes, have a look at how things are coded up. There'll probably be some kind of link between ESR and your budgeted establishment. Make sure that's reflective, because that will be the starting point for your plans that are submitted. So it details your financial year 17-18 actual. It will do in your pack, it doesn't do on my previous slides. But it also tells you what the plan is for 18-19 and where we are today in terms of the actuals. So it is interesting to see that those actuals probably for 17-18 were also above when you look at the plan.
So, can I ask you a quick question? Say where the green dotted line is the 17, 18 actuals,
Yes.
and then the big thick pillar
Yeah.
is the 18, 19 actuals.
That's, in terms of big column, that's your plan.
That one's the
Oh,
plan.
am I telling you
No.
right? No, I'm not.
No.
It's blurred on this
No.
slide, I'm sorry.
So,
Yeah, so
Okay.
that is your, so the
So
that's your plan
yeah,
there. That's your 17-18 actual,
yeah.
and that's your 18-19 actual
So
to
it
date.
looks like there's been a massive increase, or mine is the same, a massive increase in the workforce between 17, 18 and 18, 19.
Is that your actuals?
Which I wouldn't recognise
Okay.
in the workforce that I see, but that's what it says on
Yeah.
here.
And
Is
that's,
that-
those are all the things to take back, aren't
Is
they?
the dotted line the
That's
17, 18
17-18 actual.
actual?
Yes.
Okay, not 17, 18 plan.
No, 17-18 actual.
Oh,
So
yeah.
does this only account for people in post? It's not vacancies.
It's not vacancies.
Right.
The plan will be. Your plan
The plan
will
will account
account.
for
So
vacancies,
that's your
but this
budgeted
data
establishment. Your budgeted establishment is in effect your plan
Right.
in most respects. And then you've got your actual, which is those people that are bums on seats, if you like. Yeah.
Okay.
Yeah.
Okay.
So what to look for? She says.
Can I ask if we've got locums and they're registered, are they included in our actuals?
It doesn't matter what they're coded up like and who they are, if they have got a WT assigned against them. So if they're assigned a 0.4 contract as an example, they'll have hours assigned to them. If they've got 0 hours because you're doing it as an as and when, they won't be included in your staff and post actuals. Yeah. So what to look for? This is looking at loads of plans. So planning flat lines. It's not really how things work, is it? So just thinking through that. Plans which are front loaded and back loaded. So this is where you get to question. I would look at a plan and think actually they're planning for a big decrease from the onset of April. I would question that because in terms of the plans they're submitted quite close to April. You may have a consultation that you may need to do with staff. It's a WTE reduction. Also backloaded plans. It does feel that that's just a financial plan that's been submitted. So there's those sorts of things to look for. We've already said, haven't we, where do your plans sit with your actual? How does that feel? Do the plans commit to the same again? Do you know that the same again isn't right? Have you had opportunity to influence some of that? Is there confidence in ESR? So when was the last time that you looked at ESR? Great. Love you.
I look at it probably 3 times a week just to amuse myself. Because it does change often on a daily basis. It's a mystery. And it doesn't matter who you speak to in finance, HR, workforce, they all deny it's them that fiddle with it. I know the one person that isn't allowed to fiddle with it is me, and yet I'm the one that probably understands it. So I really am very worried about the integrity, the true integrity of ESR. And I always worry that we are being measured against something that is flawed.
Let's harness that energy. Because absolutely, from a workforce person, I'd be thinking, I would need you to help me code staff up right. And I think it's a mutual thing that we're both interested in getting this done. One of the things that we are going to think about, what we are going to do, is basically a quick guide. And it's a quick guide which helps you as a clinician understand what needs to be done and how you need to input into that process. And open up that conversation with HR really about how things are coded.
Can I pop in
I
here
can
as
see
well?
that you're itching.
Yeah, because what we're going to talk about the model hospital next. The model hospital is the online portal that plays back trust data. And one of the principles, again, of the Carter programme is that we need to get trusts owning and quality assuring their data. So when we first when we first put stuff out there on the model hospital, nearly every trust came back to us and said, that's not right, you can't put that on there, that's not right. And what are you going to do about it? I was like, well, do you know, I'm not going to do anything about it because it's your data, what are you going to do about it? And so there has we're sort of on that, maybe the reason why it's changing so much is because someone somewhere is still trying to fiddle with it and get it right. But what they're not doing is engaging the people that can help them do it. So I do think there's genuine activity in trust where they're trying to starting to understand the significance of the data being played out in the not in the public domain but in the public NHS domain. And so therefore people are trying to make it better, but we're still a long way from having it accurate.
And there is opportunity. It's like what we said there about codes not being available. There is opportunity, and I would get on my soapbox and say it's not representative, and I expect to be doing the same again out of some of the projects I'm working on. So watch this space. But in terms of overall, have you been involved? And can I just have a show of hands? Let's just be honest. It's Friday afternoon. Have you been involved in the plans?
We get good plans, but actually when I see the final, it doesn't often look like the discussion that I had.
And do you ever have the opportunity to find out why?
Yeah. And I think it came up earlier, it's that challenge, and I think it's a real challenge for trusts, that actually they're forced to submit these plans and align them with their finance, and actually that, and sometimes people can't see a solution around it. And actually when those cost improvements are against professions as opposed to service, that just adds to the complication. So I think sometimes it's we know that service is decreasing, so we'll just take a bit of everything, because we, rather than work out to the finest detail how many nurses, how many social workers, how many OTs are in that service. So they're involved in the discussion, but what is submitted doesn't always reflect the discussion.
So I'm putting you on the spot here, Sally, I'm sorry.
That's
But
all right.
thinking about all the evidence base that we've discussed, the opportunities, do you think that will be a huge help to you in terms of framing that conversation going forward?
Definitely. And one thing that was, we did a lot of work on our codes for our registered staff probably about 3 or 4 years ago, because and it was a huge task. We had to people register in all sorts of interesting ways. But actually our support staff data is still wrong.
Yeah.
So that is on my list, and it's slipped down my list, so based on today it's back near the top. To get that right.
Agreed.
Because that, I think we've got, from memory, we've got about a quarter of our support staff showing there's AHP support staff still.
Yeah.
So that's my big takeaway.
It does feel, I feel that is an opportunity for the support staff. I don't think we've got a representative support AHP workforce as it stands, whether that's because there's some hybrid roles there that are potentially touching upon supporting to medical.
Because, they've been coded incorrectly, they've been coded as HCAs.
Yeah. We had that
I've worked on this in the past, but it's still not right, so that's my takeaway action, to get that right.
So trying to get back into a positive thinking, so much opportunity there, isn't it, to kind of try and make an influence on this, it's fab. So have you been involved? Can you be involved? What opportunity have you got there? So just play that question back to you. Sorry.
You should be involved.
Yeah.
It's absolutely crucial. It comes back to the leadership bit.
Yeah.
And so if you haven't got accountability for that in your organisation, that's the conversation you have to have.
Yeah.
Somebody has to be at the table having these discussions. The person that knows about AHP is the person that's responsible. And if there isn't that responsible head person, then we have to have that narrow conversation about leadership.
True.
Sorry to be causing about that, but it's like it's just I'm so passionate about it.
It is a real risk. I'm just playing out my experience. In the first year that I was in an acute provider trust, I pulled together the workforce plan. We knew a lot more about the nursing workforce and the medical workforce. So it was just okay to apply a reduction to the HP. It's got to come from somewhere. So actually, having all the evidence there, I'm putting it out there, but that might be what's happening. So let's not let that happen. It's an opportunity.
So
I'm going to get beaten up here. I am a minority answer.
Go, you go first.
Can I go first?
Do.
I've been waiting 1 minute. So can I ask, when that was then submitted and you saw it had been completely changed, out of interest, what did you do, or what we?
Well, I went to talk to the HR person.
Right.
And I think it just comes down to this conundrum. And it's something you just keep battering away at, don't you?
Yeah, and I think
each year you have the conversation and you kind of turn it around a little bit.
It does. Gradually, incrementally, it gets better.
I think you do have to look at it in the whole, and actually, if I was, one of the heads of nursing looking at that, I might be having similar, views about some of those numbers aren't accurate. But I think it's putting it in that context, but that doesn't make it an excuse.
No.
No.
And I was just going to add that pretty much every one of these events, and lots of other times as well, people bring up the whole thing about the therapy support staff, the more blended roles, generic roles. They don't have a code, but we have a there is a governance structure, isn't there, for how we inform the changes and the coding that we need to ESR, and so someone in your trust will be responsible for that within that governance structure about having those conversations and feeding into that group. So why is it, as a workforce, those changes aren't on the list of things that are going to be changed? Because we're really good at saying that's not right for us, full stop. So it's about, that's not right for us, so how do we change it? That's where we need to get to. So find your ESR person, explain why the code doesn't work, ask them to raise that at the group, ESR group, whatever it's called.
Yeah, there'll be an ESR user group. There's the opportunity, I guess, through the LWAB as well, to potentially raise some of the issues if it's not reflecting right.
Because if that pretty much has to be the same for every trust, because we know those codes don't exist. So if every trust raises that same query, you'll be higher up the list of things that might need to change.
Very well articulated there,
So it is about offering the solution.
Yeah.
So understanding what it is at the moment, and then finding the things that we can request to be changed. I'm not saying it will happen quickly, but that's another
It
conversation.
is quite a bureaucratic process, but if there's more people saying the same thing, there's more noise. So it's something to take note.
Helpful
noise. So getting back to workforce
Surprised someone
planning.
hasn't said AHPs into action yet, but
Yeah.
Yeah, that's.
So workforce planning, and it is big, and it's a bit scary and daunting at sometimes when you think about what you've got currently, where you need to be. So that old cliche, what do? You break the elephant down. And I have said that workforce planning feels a bit more like a hairy mammoth of a job to get through. I'm sure a lot of you will sympathise, but it is about taking a step at a time. I'm just going to step to one side, but just in terms of the planning methodology, the 6 steps methodology is the well-renowned process. There are other ones, but this just puts you into basically thinking through of a method. It's a tool. You can use it for engagement as well. So it does tick a lot of boxes. There's lots more information on this for the Skills for Health website. They've got so much to go at on there that will really support you with that. Let's break it down. Now, I have to apologise because normally this would probably take a day to break it down, so I am going to give it you in 5 minutes. I'm going to machine gun you with workforce planning methodology. So the first step, define a plan. Why are you doing what you are doing? What's the plan? Is there going to be an improvement? How are you going to measure it? Number 2, mapping the change. So how are you going to achieve it? What changes are required? What changes are likely to be going off around you that might impact the delivery of your plan? So like we said, you know, that view of services increasing, AHP being an afterthought, how do you get in there and know that sort of stuff? What's happening? What happens if the plan is successful? What does good look like? What does it mean if it's unsuccessful? What's the risk there? 3, defining the required workforce. So this is where you can use some of the job planning information that you'll all have up your sleeves. So what typically will you need to deliver X, Y and Z? What we're talking in terms of time, what we're talking in terms of skill. And obviously the competence requirements as well to deliver some of that. 4, understanding the workforce availability. I'm going to put it out there, but when we got plans in for nursing at the time, there was really significant shortages, and there still are. They just submitted the same again. They didn't consider what the opportunities are for what different might look like. So it's a challenge back to yourself. What is the supply issues? What can be done differently? Can it be done safely? Thinking about the options that are available to develop and build the workforce. We're talking new roles, or we're talking retraining people? What we're talking about there? What do you think? And this is probably, to be fair, this step, linking into the action plan, is probably testing what you thought the solution was in the first place, because we all go into a plan, don't we, thinking, I know what the answer is, this is what we're going to do. But actually those steps before, just test that. It might be the right answer, you might absolutely know, but it just tests your methodology and makes it easy to explain to others. So when you are engaging and putting across a convincing argument as to why you are doing this, it's all there for the grabs. In terms of developing the action plan, so what are you going to do? What's the expected requirements? How long is it going to take? Where are the gaps? What's the time scales? Who's going to be doing what? So this is the nitty-gritty stuff of planning. 6, implement, monitor and refresh. So it does really, when you go back, it's PDSA, isn't it? It's looping back on itself. So it just gives you the opportunity to look back. Does that feel right? Tested it. In terms of the goals, have you delivered goals? So it's quite a straightforward planning methodology. There's a lot more to it on Skills for Health. So if you wanted to get into the detail, you've got that to go at. How does that feel for people? Yeah, liking a methodology? So again, I did say there, job planning, and this is where I'm going to loop back myself. All of that evidence, all of that information is really critical to developing your plan. It's the evidence, it's being able to put that plan across and say, this is why you need this. So, I'm sorry about this. But this is what it feels like sometimes, isn't it? And sometimes you do need to just plot it all out and think about, what's the strategy here? What am I trying to achieve? Who are my stakeholders? How does it all interconnect? And it is busy because it was a bit of an awesome task, really, awesome question. So creating a sustainable, flexible workforce in the London region, wouldn't that be nice? So just thinking about your mission statement, really, and thinking about the currency of who you're talking to. Are you talking to your finance leads? What's the language you're going to use with them? Just thinking through how you engage with people. And the methodology is really just an engagement tool. That's all it's about. It's about getting those right people around listening to you. So I referenced the operational workforce planning toolkit. Everyone's got access to it. And these are some of the things that I think are key headlines from that, which are, I think, essential for good workforce planning. You're involved, number one, no brainer. So this time next year, we do the same session again. I'd like to see more hands up, please, that you are involved. That would be great. 2, considers changes to the service and the organisation. So what's happening there in terms of, you've got 2p in, 2p out, talking employment issues here now, but that is fundamentally an issue. What does that mean in terms of how you integrate those staff? 3, supported by experts. You will have someone like me who's a keen being in your trust who will want to get stuck in and help you with this. So thinking about who that person is in HR, who's that person in finance, and they will be there and they can support you with some of this work. So 4, considers local organisation plans. There used to be a time where we just plough through, wouldn't we, and develop a plan. Okay, we're not bothered what the neighbour's doing, but let's face it, you need to know, if you're all going to be increasing and going to the same pool of people out there, it's a really important factor. 5, understand the process. There will be a process. It might not feel like it sometimes in terms of your organisation and the planning approach, but there is a process, and there'll usually be someone out there who's the glue and bringing it all together from a finance, from an activity, from a workforce perspective. So get friendly with them, find out who they are. 6, utilises the information available. There's lots to go at, and it'd be mightily impressive if you've got that plan which has got all that evidence base behind it as well. Get ESR right. It needs to be right. It will be used as your baseline to inform your plan. Question, is the workforce offering you what you need at the minute? And you'll have all that information from your job planning. So is it telling you what you would expect to see? Are there any opportunities there? So just think about some of those options. Plans are considered of SIPs. So what's the SIP requirement? Let's have an honest conversation. Is there one? What's the percentage terms? Have that up front, so when you are looking at your plans, you know what you're working towards. 7, we do this in NHS improvement, should be everywhere, triangulates with activity, finance and workforce. So you have opportunity to really test those plans before they come in, and they will be tested, just to see if they add up. So are you increasing activity yet you're decreasing workforce? Is that achievable? What are you doing differently? The plans, I will touch on the process, so it's an annual process. The brilliant thing about this is that at this moment in time, your trust will be working through developing your plans. So I'd say get your elbows out, get stuck in, go and pester some people and get involved.
I would say, just going back to the challenge back to me about challenging, and if you have those conversations, I think the other thing to think about is your trust is unlikely to make a huge significant change to the plan to make so it looks more accurate, because then they in turn will get challenged about what they've been doing wrong and then scrutiny on it. So sometimes it is about negotiating some of that, how that might go in differently.
It's a bit of honesty, isn't it, about the process and the situation, and
that's not going to open themselves up to some really difficult questions. So you might have to take it step by step. I'm candidly saying in this room is that, you know, that's the reality that trusts are under in terms of their scrutiny. But at least you're having the conversations and you know what you're going to work towards.
It's an incremental process, and you chip away at it year after year. But wouldn't it be great to be in the position what Ros described of Leicester there, where they're actually considering workforce in the whole and thinking about how basically we're talking funding, aren't we really, where it goes to the right place that needs it for the sake of the patient. So it's an important one.
I'll just ask, where you happen to have a plan above your SIP.
Is this a personal question? is it a friend of a friend?
Well, no, I mean, in theory, it says on mine that there's physio plan is higher than staff in post. So where's the accountability for that in terms of that becoming a reality? And how much does that plan mean? So actually mine does show above. The rest, it looks like it's done against finance. However, that one does look like it's potentially, they've offered more physio, but they've got that wrong because I need more OTs. So
and that's the thing, it's whether you've been involved and had the opportunity to be involved and guide some of that. So if you talk about, if I say there's a workforce planner perhaps in the back office that might not have engaged with you, you might not have had opportunity to engage with them, so they've submitted what you've always had. So it's an opportunity to just get it right going forward.
But if the plan is up, will the trust be expected to deliver on that?
Your plan is what you think you need to deliver the activity. So assuming that if you aren't meeting that plan, are you meeting your activity? It's a question to play back to you, really. But
obviously I haven't written the plan.
Joe's got
but
sense.
Helen, can I, off the back of that, so I think it's a really interesting point, which goes back to the 6-step methodology, is what you see play out in trusts. They produce the plan because they're being asked to produce it for the regulator and for HEU. But then who is the accountable person that does that 5th and 6th step, which is the implementation of it? And again, so the whole process requires somebody who knows about AHP to be part of it. Because if it's not right in the first place, then in terms of implementation, what does that mean? Who then implements what it says in the plan? I suspect that 6th step possibly falls off the cliff in many organisations. It probably happens when the planning round comes out again, they just put in what they think.
So it's meeting the requirement for the request, but not necessarily closing the loop on it.
And I do scratch my head from a HR perspective. So if we're committing to an increase, there's going to be a peak in recruitment need, isn't there? So HR aren't even planning that respect. So it's for you guys to encourage that along, really, and make sure that they're resourced.
I can go back and kind of ask the question.
Why did you say more physios? Obviously somebody in planning for. And I quite like what physios do. We say that we'll have a few more in there and we might get some nurses. I'm being really facetious now, but you can imagine some of those conversations might happen, don't you? I've been part of some of those conversations myself, so, you know. Sorry, what else did you ask me? We've got to stop asking questions.
Oh no!
Good discussion.
We never have a dull moment in our team, do we? So I think there's another sort of elephant in the room in terms of the whole commissioning versus regulator kind of perspective. So historically the plans are notoriously poor because one set of people are having conversations with commissioners about what they want delivered, and another set of conversations are going on about what we can afford, and actually those two things weren't connected at all. And I do, you might think I'm naive, but I genuinely think that this alignment of E and I is partly to start to unpick all of that so that we can get to a place where we have sensible, realistic plans within a financial envelope that are clear about what can and can't be delivered. So I think the time is right. You know, we've said that already, but the time really is right to try and get involved and try and understand and influence where you can, so that we collectively are part of that more journey towards a more meaningful workforce planning process. Do you think that's fair, Jo?
Absolutely, and Sally's absolutely right in terms of, you know, holding that mirror back to us in terms of organisations have been held to account for their keep getting complete anomia this week.
I know.
Just because we're so many mums that are just doing so much work. Their control total.
Me too.
They're held to account for their control total, their bottom line, and so it's no wonder that plan is financially driven rather than actual. You know, we know that, you guys know that, but we're working in the parameters that we're working in. But again, with the alignment, I believe that Ian Dalton and Simon Stevens have a different viewpoint of the world, and are speaking to CEOs about the control total not being part of that process in the future. So things are happening and moving that will be helpful rather than a hindrance.
So when you are having those conversations, it neatly takes me into, actually, if you're having challenges with your HR department, ask them whether they've done this. This does make those recommendations, those 10, I guess, ingredients for a good recipe for workforce planning. It does say that clinicians need to be involved. It does say that it needs to be multidisciplinary. So I think it's a fair challenge. If you are getting pushback, ask them whether they've done it. Got my permission to do that. Integration. So in terms of the AHP workforce, I'm just going to talk you through, because obviously it's not just an AHP workforce plan, it's a trust workforce plan, so it's all of those workforces together that come through to us. 3 plans that are submitted, and I've touched upon that earlier. The plans this year were a refresh of a 2-year position submitted a couple of years ago. In terms of what that means for next year's planning round, this year's planning round, I can't tell you at this stage. It feels that it could be quite a short-term plan again, so just bear that in mind in terms of it does feel more operationally focused. The submission of the plan, so it can vary, if I'm honest. So the plans this year, there were 2 submissions which were formal submissions, and then there's the opportunity to go back and actually develop some of those plans where we think it's needed with trust. In a nutshell, the plan details the WTE for the workforce. It's broken down into probably professional group layer, but it also has some KPI data on there as well. So we'd ask for things like turnover, what's your sickness absence level. So you can see why we'd ask that, because actually all of that informs what your expected workforce planning level should be. Regional teams will do an initial assessment of the plan, so they will work with your trust leads and work through that plan. In terms of the data, obviously we do map against where you've submitted in terms of your plan. But I think it's fair to say that we do actually collect the workforce information on a monthly basis. But I'm keen to really look back at your ESR data, because that needs to be the right submission. That's there. That's what's on your system. That's what's coded up right. So just to give a very slim overview of some of the things that we are developing. So these are next steps. This is all about moving from that place of feel to fact. It's 2 projects in essence. So we've got workforce utilisation. We've learnt a lot from the nursing safer staffing. This is taking us on that journey, and we're at the very start of that journey. We're looking to help develop tools that will give us that benchmarking information, and in essence it's 2 tools. So we're talking one which is in-bed focus, and that will be an update of the Safer Nursing Care tool, but we're talking about whole new development which will look at anything that's non-bed based. So that's the first project. Job profiles. So job profiles as they stand, probably not reflective. As a workforce planner, I might use those to understand what we need in terms of workforce to deliver what. There's gaps, and I've tested this with you, and you acknowledge that there's gaps there. There's gaps in profiles, full stop, and there's gaps in competency level. So there's a lot of opportunity there. Those are the gaps. What we did here, that some of these groups are taking action themselves, which is really great. And they're actually closing down and updated those profiles, so that's fab. But there's lots of opportunity there, and I think one thing to say about this is, how do we incorporate leadership potentially into job profiles? Is it something that runs as a thread through? Is it something that is a profile in itself? And these are all things that we need to explore.
Helen?
Yes.
I don't know whether, are people aware of job profiles? So they're on NHS employers' websites. Some people might not be. This is the beauty of having Helen in my team, because she sees things through a different lens that I don't see, and she seems to. Joe, you've seen the job profiles on NHS employees, and I think I looked at them like a few years ago and thought, oh, well, they're a bit useless. I decided not to go back to them, but actually, again, the lens that Helen offered to me was, Joe, if these aren't right nationally, this is what other people are going to look at to say, what is the totality of the offer that AHPs can bring to the system? Yeah. And if it looks like, just want to go back to the other slide, if it looks like this, then it looks like there isn't any profiles for drama therapists, music therapists, ODTs, osteopaths. So have we not got those roles in the system? Of course we've got those roles in the system. But there isn't a profile for them on NHS employers. Again, do we not have any dietitians, assistant dietitians working at band 3? Yeah.
Or band 8A, band 8B.
Yeah. It's a bugbear. Because if I was an aspirant AHP thinking of retraining, maybe, might get the hook, but just thinking about how I might use these, because they're out there, and probably the next generation would just do a little search, Google, these would come up, and it's just not doing us any justice as a workforce and representing what we do. And I say we, the royal we, I feel like I'm becoming an AHP and honouring it. But it is something we need to get right, we need to update it, we need them to be reflective.
So if we got somebody with a, so I was looking at orthoptists, I know that we've got an 8B orthoptist in our organisation, how would she therefore get her profile on there then?
It'd go through, so in terms of your local organisation, it'd be a job matching process.
Yeah. So she must be job matched because she's been paid that. So
they would follow a process. So it would be looking at a similar role in your organisation that is an 8B and job matching across. Yeah. Very rare occasion you can't job match. Yeah. And then you would have to start a whole new process of developing the role.
Whose responsibility is it then to make sure the profile is on that system? That's the question. Yeah.
I'd say it's probably all of ours, and that's probably a reflection of why this has become so out of date.
That's why I was holding my hand up going, I did look at them and I went, oh, they're rubbish, not going to use them again.
Because that goes back to agenda for change, doesn't it? It's 2007 sort of, the last time we looked at those.
What I should have been doing was knocking on the door of NHS employees saying, who's updating these? How can we do that?
Okay, thank you.
Can I just ask a question? I thought on the back of the discussions about on the work that's done on leadership, that was a piece of work you were doing about looking at the profiles, because actually, say for my role, it doesn't matter what AHP I am, what background I happen to be, because it's a, so is that work on the list?
It's on the list. But my view of the work, and again, whatever you think, I know this is blank here, but my view of the work, my view is the urgency is to get it right what is now. Yeah. We've got to get right what is now. Yeah. We can develop the leadership bits as we go, because that is developing an initiative. But actually, if that's not reflective of what is now, then we're doing ourselves a disservice in many ways. And the job matching thing is a clear example, isn't it? Usually job matching, they would have gone straight to those profiles. Yeah.
And I think just expanding upon that, when I've surveyed on these two topics, so thank you to all those people who did come back and give me the view. But what was interesting when we look at the job profiles is that there's a very, very small number of AHP people who are trained in job evaluation. That's an opportunity in itself. Oh, we've got one! Yay! Hey.
I'm a consistency checker for our trust.
Fabulous. Well done.
I've done it for 14 years.
Yes. I'll be picking on you. So just to feedback really, when we went through obviously the survey, have we got a time?
Well, you're -5.
I think this is absolutely essential.
Probably a plan.
Yeah.
I think that's my fault for keeping listening.
So we surveyed on both topics just to get a feel of how it feels for you guys. So workforce utilisation. I don't think we can get really a score that's any nearer to 100% that you are in favour of this. It's about giving the evidence and giving us the information we need to inform all of those things, including workforce planning. Top 5 reasons. So basically informing decision making, understanding variation. It's about safeguarding, so understanding what those levels of workforce are, the potential efficiencies, but also better planning for day-to-day service delivery. Job profiles wasn't quite as good in terms of number of return, number of people taking part, but I think it's just that we're not using them. I think we just don't know enough about them. And I'd just like to say that we did get good coverage of sectors and regions as well, so I was quite pleased about that from a research methodology. But what we did see again is that, yeah, it is the time to update these. You don't feel they're accurate. You don't feel they're accurate in terms of content or competency. But I think in terms of what I was overwhelmed with both of these projects, a lot of people want to get involved, so that's great. That's really great. In terms of the top 5 purposes of the AHP profiles, because I think we just need to rethink what are we planning to use those for, just to make sure we're asking the right question. So careers information for aspirant AHPs. So that's one thing. Support PDP. That'd be great if you could see some pathways there. Inform the development of job descriptions. Staff retention. So just making sure really people are doing what they're expected to do. Are people working to licence? Are we providing the right stretch to move people on? Help staff develop. I'm not going to do this because I can feel the laser beams out of Stuart burning into me about time. But I will just finish up in terms of this is how I think we feel as an AHP workforce at the minute. And I think that's quite an important quote. We won't get anywhere if we just stand and stare at these things. We really do need to take these things forward. And Ros says, time's now, definitely. Okay.